All right, thank you so much, Dr. Lewis. This is wonderful. I understand there are a lot of people online as well, and if some of you are cardiologists and you did hear my presentation, it was about a month ago. So if there's some short-term memory loss, repetition always bears repeating. And the other thing, of course, is that cardiology is part of internal medicine. It's a subspecialty, so we should always know what our colleagues are thinking and doing. And so I will update us now with the Ischemic Heart Disease 2025. It was a request to talk about women and heart disease. I'll share with you that this is becoming a man's problem as well. We're going to talk about things that are not bread and butter like stents and bypass. We're going to talk about something a little different. These are my disclosures. I do serve on a for-profit board that is an arrhythmia device, so I do not think this poses a conflict of interest. All right, so we're going to start out by doing a case, and there are some questions. So those of you that are online, you'll have to theoretically raise your hand. So a 54-year-old postmenopausal female presents to the emergency department with prolonged chest pain for 12 hours at rest. She has a past medical history of gestational diabetes, hypertension, and dyslipidemia, and a family history with a father having a stroke at 59 and an MI then at 66. And she is currently on hormone replacement therapy, which is what it was used to be called, oral progesterone estradiol vaginal tablets, and hydrochlorothiazide 12.5, presumably for her hypertension. So she's in the emergency room. She is hypertensive, but she's in pain. She's not desaturated. She is obese. She has an unremarkable cardiopulmonary exam. And with the older high sensitivity troponins, and this is troponin I, if you care, she has a rise and fall in her troponins. She has fasting panel done in the ED, not sure why, but she's got pretty average lipids. And then a resting myocardial perfusion SPECT, which either that or a CCTA is often done to try to decide about going up to the cath lab. She has nonspecific ST2 waves in 3 and F, and a 3% perfusion defect in her anterior wall. Her echo, though, is normal. No wall motion abnormalities, mild diastolic dysfunction. And then her coronary angiogram, a normal left ventricular end-diastolic filling pressure, no obstructive coronary disease. So she's had an MI, but no obstructive coronary disease, no apparent vasospasm, and no myocardial bridge reported. So here's some of your test questions, and we'll revisit this at the end. So what's the diagnosis? Show of hands. Coronary vasospasm, we just missed it. Myocarditis, we would have to order an MRI. How about coronary microvascular dysfunction? All right, yes, we're preaching to the choir here. What causes that? What are the mechanistic pathways? Atherosclerosis? Ischemia due to endothelial and non-endothelial dysfunction? How about all of the above? Right, all right. These might be the cardiologists. How to diagnose it. So conservative, they have the symptoms, they have evidence of ischemia, they have no obstructive coronary disease. You just assume they have it. How about non-invasive? Myocardial blood flow reserve with a PET or an MRI, advanced imaging. How about invasive? Coronary flow reserve testing with either a Doppler or an IMR catheter. How about any of the above, right? Yeah, okay. That one, there's a little uncertainty. How do we treat it? Anti-atherosclerotic therapy, standard intensive medical therapy, aspirin, statin, ACE or ARB. How about anti-ischemic therapy? She had ischemia, alpha, beta blockers, calcium channel blockers, nitrates, ranolazine. No. How about non-cardiac therapy? There are no evidence-based guidelines. How about all of the above? Okay, all right. Sometimes tests are a little too easy. All right, so here's a harder test, and it's going to test Folks in this room probably are mostly STEM. Your aptitudes are STEM. A little art history, but there's a point of this, which is pattern recognition. So here's the test. Is this a Monet or a Manet? Both were impressionistic painters. They both were painting in the same time and era in Paris. So by a show of hands, who thinks this is a Monet? Only one. Who thinks this is a Manet? More. Okay, there will be a test. There will be answers. Same thing. Is this a Monet? Show of hands. Is this a Manet? Okay. All right. So most of you got them wrong. True to your STEM training. So this one's Monet. And it's particularly embarrassing that we couldn't get that right because it was his wife. So it's different from the Manet. Most of you got that wrong too. And this one is also embarrassing because many of you probably had this as a poster in your dorm room when you finally could drink, right, without the supervision of, or your parents saying don't drink alcohol. So, and if you were going to try to do a better job with pattern recognition, you might say the Monet has more color, less black, and it's more fuzzy. It's less edgy. The Manet, a lot of black and more edgy, more like a real painting as opposed to a fuzzy impressionistic painting. Just talking about pattern recognition, because this is something that we need to do as physicians, and we do it. We just have to train to it. So now we're going to talk about Ischemic Heart Disease 2025, or thank goodness we studied ischemic heart disease in women. So we're going to talk about an epidemic of death in women. We're going to talk about low-hanging fruit, which is looking at issues of gender, critical investigation, which is sex. Sex is a biological variable. We'll talk about the results of our labor, what happened, and then policy in our future. So this is a slide, again, if you'd been in cardiology grand rounds, or if you've heard anybody talk about women and heart disease, this was a big wake-up call for us in the 1980s, because prior to the 1980s, we did not sex stratify data. So it was one big lump. We knew that cardiovascular disease was the leading killer of Americans and increasingly around the world. And so when we did finally sex stratify the data, and the death rates here, all-cause CVD, is red are the women's bars and black or blue is the male deaths. And you saw in 1984, we had a new female majority. So if you had been told, if you'd read in a textbook, if in medical school, they said men are disproportionately impacted by cardiovascular disease, that wasn't true anymore. If we were going to say it was a sex-specific disorder, it was more prevalent in women. And the gains that men were making, this decline, was very much effective. When we said, oh, we're winning the war on cardiovascular disease, that was true for the men. 1990s was the Yentl syndrome, which was an editorial in the New England Journal of Medicine, coincident with the Yentl movie, which is a story about how if a woman wanted to be literate, to be educated in turn of the century Eastern Europe, you had to impersonate a man. You had to look like a man. So Dr. Bernadine Healy said, I wonder if this epidemic of death is because women don't look like men. So we're, again, back to pattern recognition. And so it was 12 years for the WISE, which stands for the Women's Ischemia Syndrome Evaluation, to get started, sponsored by National Heart, Lung, and Blood, the American Heart Association, the AHA, the Society for Women's Health Research, all got going. It took 12 years to recognize and take action. And of course, the joke is if it had anything to do with the prostate or erectile dysfunction, it would have gone faster. But we were grateful for our NIH getting going. So NIH commissioned a study exclusively of women to try to understand this paradox where women have a twofold increase in normal coronary arteries in the setting of ACS, acute coronary syndrome, and STEMI, non-ST segment elevation, MI, as well as STEMIs. And you can see the comparison here. These were all registries or randomized controlled trials that had core lab adjudication, blinded adjudication as to what the angiogram looked like. And what you can see is even in STEMIs, 10%, 1 out of 10 women would have open arteries. Acute coronary syndromes and unstable angina was up to 1/3. This is a lot of ischemic heart disease doesn't have what we think caused heart attacks. So this was a real wake-up call, and this was what we were asked to study. So first off is talk about something like gender, which is the sociocultural attributes. And we understand that there might be issues of gender bias, right? That if everybody thinks that women don't get ischemic heart disease, then of course they're going to ignore that angiogram that had and just say, I'm not sure what happened. It might not have been a heart attack. So let's talk about issues of this. Obstructive coronary disease, something that was studied in men, for men, and by men, starting in the 1950s with the Framingham Heart Study, right? So we had a real good fund of knowledge about that. And what's the solution to obstructive coronary disease? Plumbing, right? Bypass, stents. Now we have optimal medical therapy, which is I call liquid plumber. But this was a fund of knowledge that we really understood. We could do a lot of good in the world. Microvascular coronary disease was unknown, although if you talk to older cardiologists, they would say, well, of course, that's collateral flow. That's the small vessels. And if they're open, you're in good shape. So to some extent, this is revisionist history, but this problem is more prevalent in women. And because our diagnostics weren't looking for this, then we weren't identifying it. So back again to the Yentl syndrome, women's hearts were not looking like men's hearts, so they were not being diagnosed. And this is, in fact, then a graphic that we put together in an editorial as we were describing this within the WISE study, again, funded by National Heart, Lung, and Blood, sites across the US. Other started to, and this was 2 studies in Europe that were saying exactly the same thing. So this editorial that we put together then demonstrates that, and here's the movie, the Yentl movie, Barbra Streisand is dressed up like a man, assuming, or, you know, as a figure of a pattern of obstructive coronary disease. And what we see, of course, is that when people, physicians can make a diagnosis, they have diagnostic certainty, they will have therapeutic certainty. And this is a cornerstone of what we do as physicians. Our role is to make that diagnosis, figure it out, and determine a therapeutic path. And so the therapeutic path, of course, for coronary artery disease is low-dose baby aspirin, a beta blocker, ACE or ARB, and a statin. And you can see that the majority of these patients with this obstructive pattern are men. There are some women. These are our much older women, typically. And here's the microvascular CAD female pattern. Here's Barbra dressed up like a woman with her husband. And this is about 25% of ischemic heart disease, and it's dominated by women. And what happens is they don't get treated, right? And so more women die. And in these registries that we saw in Europe, concordant with our WISE, because the registries had women and men in their European, they were able to demonstrate this elevated gap in terms of death rates. So we think that this was explaining what was going on. So early on, again, we're talking about issues of gender. If a doc can't make a diagnosis because of perhaps a gender bias and a lack of knowledge, right? We weren't testing and we didn't have this on the boards for you yet. So people didn't really know what they didn't know. So what happened, though, is this was concurrent with our guideline campaigns. And as randomized controlled trials came out, often in men, for men, and by men, showing that baby aspirin, beta blockers, ACEs and ARBs, high-intensity statins, the liquid plumber approach was really making a big difference. We had, at national level, guideline campaigns. Doctor, If the patient had a heart attack, acute coronary syndrome, they should be discharged on these 4 magic pills. And in fact, you know, we do a pretty good job sometimes with guidelines. So this is work from someone else, and it's, I would have made a better figure. So I've color coded it for you. So following guideline implementation, mortality for women improves, right? So now it's not about, are your arteries open or not open? It's about, did you have an acute coronary syndrome? Did you have a heart attack? You can see the men's lives. This is the before and after for men. It didn't really change. Well, they were already getting guidelines therapy. And in fact, they were already doing pretty well. So they fall right on that curve. If we thought women and men should do the same for their acute coronary syndrome, that's the blue bar. And there's some reasons to think that maybe they should do the same or even better. All right, so that was issues of gender, sociocultural. Let's now go on to critical investigation, which is the role of sex. Sex is a biological variable. So the prevalence of normal and non-obstructive coronary disease continued to roll out as we do more and more interventional studies, and you know, tremendous amount of knowledge, and many of these were asking yes, no about different types of stents, but they were all, again, core lab adjudicated. And so what you see is as time marches on, we continue to see this important sex difference of women are more capable of having acute coronary syndromes and heart attacks with open arteries. But fast forward to our last 10 years, this is now common in men. So this is the VA CART. It's a national registry of all coronary angiograms done at any Veterans Administration in the US. As you might imagine, folks in their 50s, 60s, and 70s, veterans, still are mostly men, even though 1 out of 5 soldiers now is female, but they haven't quite aged into this group. So this was almost all men. But what you can see is that over half of the angiograms done now in our veterans have no obstructive coronary disease. And one of the things that, this is another talk, but the over-the-counter aspirin, primary care physicians dispensing statins, better control of hypertension, and reduced cigarette smoking in our elderly have all started to change this disease. And then and those are all good things associated with the diabetes epidemic. Small vessel dysfunction is becoming more prevalent. And we probably will see in this next decade, it'll be about equal. Women and men will have this small vessel dysfunction as underlying etiology. So what do we know about this then? Well, when we look at these registries, we'll see atherosclerotic disease continues to be dominant, right? And when it's obstructive, then we know what to do. And there's a lot of clinical trials that are trying to help us optimize how we make these decisions about interventions. We also know that there is vasospastic disease. Remember, that was one of the explanations. Was it vasospasm? Was it vasospasm that caused a heart attack in our case? And this is also sometimes called Prince-Metal angina, and it's still there. It's in the books. In our hands and in some of these registries, it's only about 3% of what we would call ischemic heart disease. So it's not highly prevalent. And yet, if you have a patient in your practice that a calcium channel blocker takes care of their chest pain, and they only come in to see you once a year to renew that medication, and you say, well, I don't know, do you think you still need it? And they're like, give me that medication. Those are your Prince-Metal patients, and they typically do very well over time. So the dark side of the moon was the microvascular dysfunction in the coronary microcirculation. And one of the things that we're increasingly starting to describe, again, another lecture for another day, is some overlap to the more severe form, which is a Takotsubo syndrome. It looks like a cardiogenic shock. But also, we think that this small vessel dysfunction can overlap and can be background therapy. And so it really behooves us to understand it and go further. The microvasculature is really the vascular resistance. And if you've spent time in cardiology and spent time with cardiologists that are doing less of the plumbing and more of the thinking, you understand that coronary physiology turns out to be pretty important, and it's not always just a plumbing problem. So epicardial coronaries normally contribute less than 10% of the vascular resistance. Remember, those are the ones that we plumb. That's where the stents and the bypass go in. But hemodynamic significance is present when there's over 70%, and stents and bypass do save lives in the right situation. Coronary microvascular, on the other hand, is responsible for that greater than 70% of the coronary resistance. And so these are the deal makers. The microvascular is really directing the symphony. We and others have demonstrated that if you wanted to sort of really simplify endotypes, there's the impaired vasodilation endotype. And you can see that these are the ways that the coronary arteries auto-regulate themselves, as well as how the autonomic nervous system regulates the small vessels. So it's a complex interplay. And then the other endotype is the increased vasoconstriction. And again, these are both mechanistic pathways as well as ways of testing. These are pharmacologic ways that we can interrogate and decide whether or not somebody has microvascular dysfunction. Working with a number of fellows who have been with us over the years, now faculty at many different institutions, we've been able to show that 2/3 of these patients do have subclinical coronary atherosclerosis. So we believe, or we're testing the hypothesis that that is probably a mechanistic pathway. And yet up to perhaps 25% have no evident plaque, not even non-calcified plaque. And they just have a functional or an anatomical problem. We've demonstrated that the inability to dilate, to flow reserve and not have angina going up a flight of stairs, or not have angina in a heated discussion, this is our worst pathway in terms of prognosis. It predicts adverse events as well as death. The impaired dependent coronary reactivity, the increased vasoconstriction, this really predicts a persistent angina. It's often very hard to treat. And these are the patients that are going to be the more frequent flyers back in the emergency room a year later, back in the emergency room again, being hospitalized for a possible acute coronary syndrome. More mechanisms. We did intravascular ultrasound, IVUS, of the coronary arteries. That was quite novel in the 1990s. And behold, 80% have not a small amount of atherosclerosis, even though on an angiogram, a luminogram, the invasive kind, all you see is the lumen. So you don't see the walls. We are better off now because of CAT scans, right? The coronary CTAs, where you actually get to see the plaque. But this was surprising at the time. Wow, she has a lot of coronary atherosclerosis. We also were able to demonstrate that these stress tests that were abnormal were true positives. So if you look again in older textbooks, even some residual textbooks, women have a higher false positive rate for stress testing for unclear reasons, hormones, digeffect, et cetera. And therefore, it's a false positive. And what we were able to do with one of our WISE sites is we used magnetic resonance spectroscopy, not imaging. This is a pure research tool. You would not find this in clinical care. And it's looking at metabolism in the anterior wall of the myocardium. So phosphocreatine, a true Krebs cycle, like was the tissue ischemic? And what we demonstrated is that a majority of these patients with abnormal stress tests but open arteries had the same amount of ischemia as somebody with an important LAD stenosis and substantially less than reference control populations. So this is true ischemia. We also demonstrated, again, using these invasive testing, that the coronary flow reserve less than 2.32, and that's a female threshold. The male threshold is 2.5. But this predicted death, myocardial infarction, stroke, as well as, curiously, heart failure. And this, again, for a presentation for another day, but it looks like this is a leading into HFpEF, heart failure with preserved ejection fraction, which is another currently female-dominant disease. We then pursued what we call randomized pharmacologic probe trials. Probe in the sense that we have a drug on the shelf, we know what it does, we know what ACE inhibitors do, and let's test the microvasculature in a randomized, blinded and/or crossover. We had a number of different trial designs, relatively small, right? Because the outcome was either flow reserve or perfusion by a MRI. And this is just giving you a sense mechanistically. This is not a big outcome trial. But we early on got a hit, quinapril, ACE inhibitor, increased coronary flow reserve, reduced angina. Who knew that ACE inhibitors are anti-anginal? But they do a lot of good things. So we did not get a great hits otherwise. We had an early hit in a small pilot study of pretty severe patients, a signal that their perfusion was better, but in a larger heterogeneous group, we didn't. And others, Amir Lerman at Mayo Clinic had demonstrated that a high-intensity statin can improve endothelial function. So we had a couple of hits and therefore designed a big outcome trial. So the WARRIOR stands for Women's Ischemia Treatment, Reduces Events in Non-Obstructive Coronary Artery Disease Trial. This was funded by our congressionally directed medical research program of the DoD. And you might wonder, why does the DoD care? Why do they have this medical branch and they fund medical research, particularly in women? And again, our project officer said, well, the 1 out of 5 soldiers are female now, and in the military, we like to get ahead of problems. We don't like to be surprised or behind problems. We were like, bring it on. So the investigators are listed here, and we had planned to randomize 4,422 no obstructive coronary disease, and the intervention, again, off the shelf from our pharmacologic probe trials, was high-intensity statin, ACE or ARB, versus guideline-directed, which was usual care in the real world, for reduction of all-cause death, non-fatal MI, stroke, hospitalization for angina or heart failure. I think I have the design here. Yep. So the intensive medical therapy arm was provided to the participants randomized. It was open label, but the outcomes were blindly read. And I just literally presented this a week ago at the American College of Cardiology, so I don't have a new slide yet. And also we're a little embargoed for presenting a lot of that until we get our paper out. It was a neutral trial. We were adversely impacted by the pandemic. We recruited only about half, so we had about half of the power. A sensitivity analysis that also adjusted for crossover, which we anticipated, and so this was a pre-specified analysis, did suggest that we would have seen a 25% risk reduction had we been adequately powered, with just the confidence intervals were way too broad. So what's the take home? Do not do a trial in a pandemic. Okay, so results of our labor. What has happened since we've been doing all this work? Well, again, here's where we started. Here was the decades between the late 90s and early 2000s. Those arrows are each of the NHLBI, Red Dress, Heart Truth, AHA, guidelines from ACC. And so we would like to think that this had something to do with it. Of course, this is all observational, so we can't take definitive credit. But we do think that also that the cardiovascular treating of the team, the heart team, is fairly responsive to inpatient guidelines. And I think that probably made a pretty big difference. So where are we going, policy in our future? Well, again, thank goodness we've been studying women for 25 years, because we have a new epidemic called type 2 MI. You've probably heard about it if you've been in your cardiac intensive care unit, but it's most commonly a woman. It's most commonly a woman that this is a comorbidity. They've come in from a nursing home. They is a man in urosepsis. It's a patient who fell and broke their hip. And why the emergency room physicians order troponins, I don't know. because we say this is not a primary problem. But anyway, the point is, it is a problem, and they're just doing their job. So type 2 MIs often will be mild or no plaque, or even a fixed atherosclerosis, but it's just the stress and the strain of the comorbidity. We don't really know what to do with these, but we do understand that it's a new problem. STEMI rates in the US have fallen by 50%. Thank you, primary care physicians, because it's mostly their work. Because STEMIs often, it's the first time anybody had a heart problem as they present with a STEMI, right? So, but these type 2 MIs now are the result of us, I think, taking good care of people, but they're very capable of having MIs called now MINOCAs, myocardial infarction with no coronary artery disease. So we need to know more about these. Thank goodness for the study of women. We have a leg up with type 2 MIs because we actually have new chest pain guidelines. Dr. Martha Galati, my associate faculty member in our center, led those. And we also have new ICD-10 codes. So there's a code now for INOCA, ischemia with no obstructive coronary disease, and MINOCA, myocardial infarction. I wasn't part of that advocacy group. I'm not 100% sure that it's right, because physicians need to make diagnoses, and MINOCA has a lot of potential diagnoses underneath it. Yet, I think, hopefully it will help us do a better job, because this is what we continue to see is no obstructive coronary disease. We still will see a relative gap in call the cardiologist, get them on a statin or some other kind of intensive therapy. So maybe these codes are going to help. Here's where we are contemporary, and these curves are going up before the pandemic. So we can blame the pandemic for a little bit, but we have a very real problem of backsliding, and those demographic shifts that I told you about, where STEMI rates are going down, more men are being diagnosed with ischemic heart disease and no obstructive coronary disease. This is part of the problem. And then we have increasing diabetes and social determinants of health that are probably should be in our lane, right? So what are we going to do about that? More work ahead. Okay, so we're going to now go back to our case, and we'll see if you can guess even more righter. So our patient did go up to the cath lab because she had that abnormal SPECT, and she had a rise and fall. So she had a heart attack, and she had a heart attack with open arteries. So you can see here, she has mid-LAD bridging, and bridging, the cardiologists get excited when it's a functional bridge. It's almost always more proximate before the arteries are diving into the myocardium. So what we more often see is it's not a functional bridge, but it serves as a nidus for a focal area of atherosclerosis and endothelial dysfunction. And so microvascular spasm. And in fact, this is what she has. She has plaque at that area. She also, in response to adenosine, again, remember, we use these pharmacologic probes that we know what they do. So we have adenosine receptors pretty much all over our body, but they control a fair amount of the microvascular resistance. Instead of getting dilation, she has vasoconstriction, and her coronary flow reserve is well below that female threshold of 2.32. Resolution of vasoconstriction with some nitroglycerin. And then when she was tested, this is a secondary angiogram, her LV-EDP was 18, normal is up to 12. Why is the pressure in the ventricle elevated? There's no valve dysfunction, ejection fraction is normal, probably due to resting ischemia, which is another diagnostic pathway and potentially leading into what we call HFpEF. So what did we do? Well, we gave her a diagnosis of ischemic heart disease with coronary microvascular dysfunction, and she had some coronary vasospasm. She has mid-LAD bridging with no significant systolic compression. It's not a functional bridge. And she had an NSTEMI, and we had done an MRI for myocarditis, but she has a late gadolinium scar. So she really had a heart attack. I mean, there are some people that still say these, troponins are not reliable. And you're like, I don't know what is more reliable. But a late gadolinium scar in an MRI is very reliable for a heart attack. And then diastolic dysfunction, we treated her with baby aspirin, an ACE, an alpha beta blocker, statin, nitroglycerin as needed. Hormone replacement was discontinued, and again, a talk for another day, but women's heart disease is not hormones, and referred to cardiac rehab. And she's done very well. SAQ stands for Seattle Angina Questionnaire. This is a fairly easy. The SAQ-7 can be done in your clinic time. They can be filling it out while they're waiting for you. And a SAQ score of 100 is perfect. You have no chest pain, you have no disability. So she started out at 67, and 1 year later she went up to 74, and that's a clinically relevant change. And she had no further myocardial ischemia or hospitalizations for angina. So one more time, what's the diagnosis? You guys got it right the first time. Our reputation precedes us. All those publications you must be reading. All right, and what causes it? We think so far these pathways, and it's disappointing that our Warrior trial was neutral, but we'll learn a lot. We learn a lot from all trials, so we'll have a lot of secondary analyses. How do you find it? Yeah, any of the above. And particularly if you've got a patient that's 65 or older, and they've got some treatment targets, they're hypertensive, they're dyslipidemic, they're overweight, A1C is elevated, just start treating them. And often their chest pain will get better, especially if you send them to cardiac rehab for some interval training. How to treat it? Yeah, we're still in that treatment phase. So we've taught you now, hopefully, a lot about how to diagnose it. And we're just going to have to do more trials to really understand how to treat it. But many of these anti-anginal therapies can help. And they don't get rid of the chest pain, as you saw in our case. She still has chest pain. But what chronic disease do you have that you can get rid of it? So, all right, now you have the opportunity to redeem yourselves, STEM people. So the one on the left, is that a Monet? Show of hands. Or a Manet? Okay, most of you got it right. Oops. I'm sorry. That's the Monet. And what's the pattern? Color, fuzzy, right? Okay, on the right, is this a Monet or a Manet? Good, you all got it right. So black, use of black, generous use of black, kind of more edgy. You can see her face. Yeah, okay. All right, so let's conclude. Ischemic heart disease is prevalent. It's the leading health threat for women and now men. There are sex and gender differences in heart disease presentation, myocardial infarction with no obstructive coronary disease, new term MINOCA, and type 2 MI are increasingly common in women and men. Diagnosis can include empiric, advanced imaging, invasive methods. And this is what we know so far. And emerging data does support statin and ACE and ARBs. Large outcome trials are ongoing and needed. There was also a trial in Sweden, in the Sweetheart, that was a MINOCA trial looking at beta blockers and high intensity statin. And they were probably just smarter than us in Sweden, because when the pandemic hit, they just stopped the trial and saved their money for another day. So I will close with that. These are my research team on the left, meaning they're clinicians as well, but they make the research enterprise go. And then this is our clinical team on the right with a couple of advanced practice nurses. And we always want to thank our research support, which is the fine print, but more importantly, our participants. And we've had really excellent enrollment of women. And so if you've been having trouble enroll women in trials, please come and talk to us, because I don't understand why other people have trouble. And it might, if you put women in the title, we think that probably helps. All right, so I will close with that and happy to take questions if anybody has any. Thank you.
We have a few questions online, but wanted to go to the room first. Any questions?
Reward those that show up.
Oh, here we go. Oh,
Thanks so much. You have a lot of NIH funding there that's funded this work. How are you approaching the new reality where sex-specific trials might not win you favor?
Yeah, no, it's a very valid concern, and every day, you kind of go, phew, they didn't pull that one, but then it's another day, right? So, and you're probably aware a list of search terms, and they look at the abstract, the lay summary, and the aims page. This is the strategy. And women is on the bad list, men is not. So, in case you weren't already paranoid, they really are out to get us. The DOD and PCORI so far have not had anything pulled. And one of the things that we started doing about 10 years ago is including men. Partly because of this, the VA CART data, partly because a few reviewers said, aren't you being discriminatory? And we came around, which is to say, when we first started WISE in the early 90s, we actually went back to our project officer at NHLBI and we said, we need a control group and we need men. The best control group we think to study sex differences would be men. They said, absolutely not. You enroll one man, you'll fill it with men. We've seen this before. It was, and we were like, oh, okay. So we had, 15 years of no men. And then as things started to change, we've actually included men. And I got a great score on a U54. And I've been told by my project officer that it likely will be funded. They're just because of this continuing resolution and these big grants, if they don't have a budget, they don't know when it's going to happen. So it's a long-winded answer that yes, we're worried about this. And we'll, if they shut us down, we will just publish from our registries and our bio repositories. I think we could probably limp along with that. Yeah.
Hi, I was wondering if you could comment on whether you guys have any kind of standardized pathway for patients come in with NSTEMI, they get a CT or invasive angiogram, they don't have obstruction. When do folks get invasive functional testing? When do folks get MRIs? What sort of treatment pathways do you use? And is it standardized or is it very provider dependent?
Yeah, it's not standardized. I'm in a big medical center with, a lot of things that we don't, I don't know how your hospital goes, but we have 3 flavors of physicians. We have employed faculty, the academics such as myself, contract physicians, anesthesia, radiology, but increasingly, like our heart failure group, contract physicians, and then real private practice. And it's about a third. And so the dean tells us, jump, we say, how high? The contract physicians say, we need to renegotiate that contract. And the private practice docs are, help. So this whole idea that, Noel would tell all of these doctors what to do. We don't, but we should. The ED docs now order troponins almost as frequently as CCTAs, right? So there are a lot of patients with, undetermined chest pain that will get a CCTA. And the benefit, as you know, is not only do you know, yes, no obstructive coronary disease, but you see plaque and you see non-calcified plaque, which is more prevalent in younger women. So we probably should be thinking about that in terms of it has almost become an ED standard. And we could have, options that would be helpful to the ED doc rather than having to call the fellow down for a borderline positive troponin, right, for a type 2 MI going up to the ICU for urosepsis. That's like not a useful consult usually. Yeah. Good suggestion. I'll work on that.
Right, this is a question from Dr. Bonilla online. What is the role of viral infection on coronary artery disease? So for example, SARS-CoV-2 has been associated with endothelial dysfunction, microclots, NMI post-infection, and long COVID, at least right now, looks like it's more common in women.
Yeah, absolutely. And Dr. Tim Henry, who was our division chair, now he's at the University of Cincinnati, was, has a very compelling line of research and investigation. He's an interventional cardiologist, STEMI type person, that the COVID, the few cases of myocarditis, but the more frequent cases of, leaking enzymes and going into shock was a diffuse thrombotic disorder triggered by the first round of the horrible virus pre-vaccination. And whether or not that's related to long COVID, I don't know. Long COVID, here's Noel's, I'm a cardiology physiologist with essentially no training in immunology, but it looks like a long haul, inflammatory autoimmune disorder, which is more common in women. Always is, right? Always is. And the stuff that I do know that supports that statement, we're, in cardiology, we got very interested in inflammatory markers, starting with Paul Ridker and high sensitivity CRP. Well, CRP in boys and girls pre-puberty is exactly the same. And when girls go through puberty and boys go through their puberty, girls bump up their CRP and boys do not. Girls, women, have a lifetime of higher Hashimoto's thyroiditis, lupus, rheumatoid. You pick any autoimmune disease. And so to think that women are more susceptible to chronic inflammatory disorders that do or do not use the inherent immune system, it makes sense to me. So that's a good question. Thank you, but I don't have good answers.
Another one, they're sort of piling up online, but next is from Dr. Samani, one of our chief residents, who says, thank you for this lovely and poignant lecture. I imagine there's also patients who have obstructive coronary artery disease, but concomitant microvascular dysfunction, and the latter of which may be driving functional and some symptomatic intolerance more than the obstructive lesions. So how do you typically approach those types of cases, especially when we begin to consider PCI for refractory angina, from obstructive coronary disease versus MINOCA?
Yeah, no, this is, that's that slide, that European Heart Journal editorial that we wrote with Filippo Crea. It's very likely, but hard to prove, that the small vessel dysfunction is playing an important role in patients with obstructive coronary disease. Why is that hard to prove? Because as soon as you have upstream abnormal flow, you have inability to really assess the downstream small vessel flow. But if you sort of take the tenet that, a sick artery with plaque is going to have endothelial dysfunction downstream, it sort of makes sense. The problem and why it's clinically relevant, and I mentioned this early on, some people don't have that problem. And these are people with, left main and they refused intervention. People with triple vessel disease, borderline reduced ejection fraction, diabetic, should probably have bypass. They refuse it. They're still seeing you 10 years later. they probably have good collaterals and maybe good habits. But so when we do these adverse prognostications, we're usually finding that high risk 10%. Well, that means there's 90% that probably do okay. So those are the lines of data that would support that, yes, I bet it is a problem, but two, given our current modalities, and maybe AI will help us figure this out. But as soon as you see either on a PET or an MRI segmental reversible defects, you're dealing with epicardial disease. And as soon as you put that IMR catheter down or the Doppler fluoro and you've got an FFR that's abnormal, it's going to be hard to interrogate. Yeah.
Thank you. This question is from one of our PCPs, Dr. Wissing. As a PCP, can a negative coronary artery calcium score effectively rule out microvascular dysfunction?
No, unfortunately not. And again, intravascular ultrasound sort of preceded coronary artery calcification, meaning it was there, but people weren't really using it. So our intravascular ultrasound demonstrated that probably around 20% of these patients with small vessel dysfunction don't have any plaque. And that was IVUS, when we really started, we went into every artery, and then we got more selective because it's a really big catheter, and you can get yourself into trouble interrogating these totally normal arteries. So the coronary artery calcium, the fast CAT scan is holistic, right? It looks at every one. So both of these modalities demonstrate that you can still have small vessel dysfunction. What would be etiologic in the absence of plaque? Patients with lupus, women with chest wall radiation for breast cancer 20 years ago. And then we have some patients that just have idiopathic severe endothelial dysfunction, meaning we can't find anything wrong or treatable other than, supporting them. So there's always, you know what you know, right? We have the fund of knowledge, and then you don't know what you don't know. And there probably are root causes that we can't, probably, I would say maybe 10% of the patients, we just don't have a good root etiology. So, and then you do what we always do, right? It's chronic disease management. You support supportive care. You provide medications that relieve pain and suffering. And you do your best, and we say, we're researching this. We're trying to find new treatment targets.
Thank you. Next question is from Dr. Hannah Valentine. And she says also, thank
Hi,
you.
Hannah.
She's asking about what evidence is needed for confirming the link between microvascular disease and heart failure with preserved EF. And are there treatment trials, given that we now have effective treatments for HFpEF, for heart failure preserved EF?
Yeah, this is a great question. And this is something that Mike Nelson and Janet Way are working on, Hannah. So here's Janet. She works with our MRI group. And Mike is now, he was a postdoc, he's now at UT Arlington. We both do a lot of MR, and we have microvascular patients now that we've followed for 10 years. And we're trying to get funding to do another round, a 5-year later MR, because they start to go into heart failure in our original WISE cohort around 5 to 10, excuse me, not 5, 7 plus to 10 years. You'll start to see this uptick in hospitalization for heart failure. And as you know, prognostic, not just cross-sectional, but prospective studies are your next step to say, oh, we had microvascular dysfunction at baseline. And then we look at, strain, fibrosis, late gadolinium scar, mechanistic pathways about how ischemia in the small vessels could lead then to adverse remodeling, And then the other thing that Janet is doing, Janet has an R01 called Mission, and we we took this idea from Helen Hobbs, who now has shifted from, Dr. Hobbs will probably get a Nobel Prize. She found the PCSK9 pathway, right? So these amazing drugs that we have now to further lower cholesterol. Well, Helen is, a genius. And she shifted her attention to fatty liver, and this is now the leading cause of cirrhosis. I'm talking to internists, so you know this. I didn't know that before. And one of the things that Janet and I had done in that initial spectroscopy, MR spectroscopy, is in addition to doing the phosphocreatine and pH to look at the energetics of the heart, we could see fat, triglyceride droplets in the heart muscle. Not pericardial fat, not epicardial fat, in the heart muscle. What is it doing there? And so Janet has another line where we're proposing, testing the hypothesis that that is a mechanistic pathway. Fatty heart is a potential mechanistic pathway. And it sort of is starting to make sense, because look at what the GLP-1As and the SGLT, these are two new diabetes drugs, metabolic drugs. They're reducing HFpEF. So Hannah, you're always on top of it. Those are our thoughts. That's what we're doing. Hope we don't get cut off.
All right. Well, we're at the top of the hour. Thank you so much, Dr. Bairey Merz, for joining us and giving us this excellent presentation.
Thank you for paying attention. Go take care of those patients.
Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.